Frederick Douglass Hospital was founded in 1895 by Dr. Nathan Francis Mossell, the first African-American graduate of the University of Pennsylvania's medical school. Its creation answered a practical emergency. Philadelphia had black patients who faced discrimination in white hospitals and black physicians who needed places where they could practice, teach, and build standards of care. A hospital was therefore more than a building. It was a professional platform and a statement that black health deserved permanent infrastructure. Douglass also established Philadelphia's first nurse training school for black women, opening a path into skilled clinical work at a moment when racial barriers narrowed access to nursing education. Imagine the daily work behind that achievement: patients admitted, instruments sterilized, records kept, students examined, families informed, and physicians judged by the quality of care they could provide under unequal conditions. The hospital created employment and mentorship while making medical authority visible in a black institution. Its story also prepares us for the later Mercy-Douglas merger. The name changed, but the underlying project continued: protect patients, train professionals, and keep a community's medical future from depending entirely on institutions that excluded it. As you look at this stop, distinguish philanthropy from self-determination. Support from donors mattered, but black physicians, nurses, patients, and organizers supplied the institution's purpose. Frederick Douglass Hospital belongs in Philadelphia's medical history not as a footnote to white medicine, but as one of the places where the city's black medical system was deliberately built. Pennsylvania Hospital was founded in 1751 and became an important site in the development of American medical teaching. That achievement has to be held beside the history of bodies used by medicine without equal power to refuse. In 18th and 19th century Philadelphia, black people, enslaved people, poor people, and people whose bodies were treated as available could be exposed to anatomical collection and dissection in ways that were not governed by modern ideas of consent. The exact record varies by person and period, so this stop should not turn a complicated archive into one sweeping accusation. The larger truth is clear: medical knowledge has often been built through unequal relationships, and hospitals could be places of both healing and extraction. Compare this institution with Frederick Douglass Hospital. At Pennsylvania Hospital, professional medicine gained prestige within an older social order that ranked lives differently. At Douglass, black physicians and nurses built an institution in which black patients could claim care, dignity, and training on their own terms. That contrast is the ethical hinge of the tour. Ask who was allowed to become a student, who was treated as a patient, who was reduced to a specimen, and who had the authority to write the official history afterward. Philadelphia's medical legacy includes brilliant innovation, but innovation does not erase the conditions under which knowledge was acquired. A complete tour names both the benefits of medical progress and the people whose autonomy was sacrificed or ignored. The national context must be named here, even when the precise Philadelphia record is incomplete. Enslaved people were used for anatomy and medical training without meaningful consent. Grave robbing also targeted black cemeteries. James Marion Sims repeatedly operated on Anarcha, Betsy, and Lucy, enslaved women whose pain was used to develop fistula surgery without anesthesia or freedom to refuse. Their names must be spoken alongside his. These cases did not all happen at this hospital, but they reveal the recurring pattern this stop asks us to examine: black bodies treated as research material while institutions claimed the credit. At this stop, memory has to do more work than architecture. Mercy Hospital grew from the home for aged and infirmed colored persons, established in 1864, and became one of the institutions that served Philadelphia's black community in the 20th century. Its story is not only about a hospital building. It is about the people who needed care, the workers who made care possible, and the donors and organizers who understood that a community could not remain medically dependent on institutions that excluded it. Sometimes the tour has to reconstruct a place after the city has allowed its meaning to thin out. That act of reconstruction is part of the route's moral work. Imagine the hospital as a network: admissions, nursing shifts, laboratories, kitchens, laundry, records, visitors, and families making decisions under pressure. Mercy represented continuity for patients who needed a place where their racial identity would not be used as a reason to turn them away or diminish their care. It also prepared the institutional ground for the 1948 merger with Frederick Douglass Hospital. The name Mercy Douglass carried forward both histories. When a site disappears or changes function, the loss is not merely architectural. A neighborhood loses a visible address for trust, employment, training, and memory. Standing here, think about health as collective obligation rather than private transaction. Founded in 1787 by Richard Allen and Absalom Jones, the Free African Society organized Black Philadelphians around mutual aid, moral community, and practical support. Members contributed dues and helped one another through illness, death, unemployment, and burial. That may sound different from medicine, but it addresses the conditions that determine whether a person survives a medical crisis. A family cannot recover if it loses income, housing, food, or funeral support at the same time. The society also demonstrates that Black institution building preceded the modern hospital. People created systems of accountability because existing authorities could not be assumed to protect them. Mutual aid required bookkeeping, trust, rules, visitation, and the hard work of deciding how limited resources would be shared. It also created leadership. Allen and Jones would go on to establish major religious institutions, but the society itself deserves attention as an early Black civic organization. Its legacy is a reminder that public health begins long before a city health department issues an order. It begins when neighbors decide that illness is not a private failure and that the vulnerable will not be abandoned. Mother Bethel African Methodist Episcopal Church is one of the clearest places to see health as a collective responsibility. Richard Allen purchased the original lot in 1791, and the congregation traces its first church building there to 1794. Mother Bethel's own history emphasizes that this is the oldest parcel of land in the United States continuously owned by African Americans. That continuity matters because a church could provide forms of care that hospitals did not: food, shelter, visitation, burial support, moral counsel, fundraising, and trusted information during crisis. When epidemics struck, Black Philadelphians often had to rely on networks that could mobilize quickly even when official systems were suspicious, segregated, or absent. Do not reduce this stop to an unverified claim that every nurse or treatment program was headquartered here. Instead, understand the church as civic infrastructure, a place where people could be organized, recognized, and supported. Its pulpit and meeting spaces linked spiritual life to abolition, education, mutual aid, and public health. The congregation's long presence also helps explain why trust is a medical issue. People are more likely to seek help, disclose symptoms, accept guidance, or care for a neighbor when institutions have earned credibility. Mother Bethel's story is therefore not a detour from medicine. It is part of the conditions that make medicine possible. Stand here and ask what a healthy neighborhood requires before a clinician enters the room: stable relationships, shared responsibility, material help, and a community memory strong enough to survive repeated emergencies. At this stop, read the street as a social map of trust. Black Doctors Row suggests what it meant for patients to know that medical authority could look like them, live near them, and remain reachable without crossing into alien institutional space. In a segregated city, a concentration of Black physicians could support referrals, apprenticeships, pharmacies, nurses, midwives, and neighborhood knowledge. It could also give young people a visible professional future. The point is not to romanticize the block. Black physicians still worked under financial constraints, discrimination, and the enormous demand created by unequal access elsewhere. But presence itself had medical consequences. A doctor who knew the neighborhood could recognize the difference between an individual symptom and a housing problem, a workplace exposure, or an epidemic moving through families. Patients could ask questions without first translating their lives for an institution that had never listened to them. That changes the emotional geometry of care. Medicine becomes local, relational, and woven into everyday neighborhood life. As you approach, keep the route moving. Ahead is Black Doctors Row, and this stop is about presence made public. The point is not only that black physicians existed. It is that they could be seen on an actual block, in actual neighborhood space, close to porches, corner stores, family routines, and the people who needed them. Medicine here was not distant or abstract. It lived near home. Close the route here by thinking about epidemic response as a test of ethics and power at once. Philadelphia's 1793 yellow fever epidemic killed thousands and exposed the city's fragile systems of sanitation, quarantine, information, and care. Black Philadelphians, including members of the Free African Society, answered calls for assistance and performed dangerous nursing, transportation, and burial work. Later accounts often repeated racist claims that black people were naturally immune or had profited from the crisis, turning service into accusation. The historical record shows a more complicated reality. Black caregivers faced exposure, exhaustion, grief, and the same disease risk as others, while being expected to serve because white authorities wanted labor they could not safely supply. Public health is not abstract policy. It is labor, exposure, sacrifice, and the struggle over who gets remembered as a life-saving presence when the city is under pressure. End here by asking what a crisis response owes its caregivers: protection, accurate credit, compensation, and a place in the official record. As you approach, keep the route moving. Yellow fever sites is ahead, and the route closes here in epidemic time. In moments of crisis, black Philadelphians were called into dangerous care work, expected to serve under risk, and then too often denied full credit once the danger passed. Public health here is not abstract policy. It is labor, exposure, sacrifice, and the struggle over who gets remembered as a life-saving presence when the city is under pressure. At this stop, hold the tension between care and discipline without trying to smooth it out. Philadelphia's City Almshouse was part hospital, part shelter, and part mechanism for managing people whom the city classified as poor or dependent. Residents could receive food and treatment, but they also entered an institution governed by rules, surveillance, and judgments about deservingness. That tension is central to the history of public medicine. A person may need care and still lose control over where they sleep, how they move, or how their condition is described. For black Philadelphians, almshouse care existed within a society that restricted employment, housing, and access to private physicians. The city could then present institutional assistance as charity while ignoring the policies that produced unequal need. Almshouses force us to ask who received care through charity, who received it through control, and how poverty became a medical category. To understand black medical legacy honestly, the route has to include institutions where healing was offered under terms people did not choose. As you approach, keep the route moving. Ahead is the City Almshouse, where poverty, public health, and institutional medicine collide. This is one of the least comfortable stops on the route, and it should be. Almshouses force us to ask who received care through charity, who received it through control, and how black Philadelphians were expected to navigate systems that could treat need and dependency as moral categories rather than simply human conditions. Philadelphia General Hospital grew out of the city's public hospital and almshouse tradition, and was long known through the older name Blockley. That history places it at the intersection of treatment and social control. A public hospital had to receive people who could not obtain private care, but the same system often classified poverty, illness, disability, homelessness, and dependency through rules imposed from above. For black Philadelphians, access to public care could be essential while still being shaped by segregation, unequal assignments, and limited power over the conditions of treatment. The hospital also belongs to the history of nursing labor. Black nurses entered a profession that demanded technical skill while frequently denying them equal educational opportunities and professional recognition. When a public institution trained or employed black nurses, it could offer a route into medicine. It could also rely on their labor without dismantling the hierarchy around them. That contradiction is worth keeping in view. Ask who washed, lifted, fed, monitored, and comforted patients, and whose names entered the formal record. The phrase Old Blockley should not make the place sound quaint. It represents generations of people whose care was administered through a city system but had to decide who counted as deserving. Philadelphia General's legacy is therefore both medical and political. It shows the need for public hospitals, the dignity of patients who depended on them, and the danger of treating poverty as a defect to be managed. The Black medical story includes the professionals who worked inside this system and the patients who insisted on care within it. Dr. Virginia Alexander built a medical practice around the idea that diagnosis alone could not solve a health crisis created by housing, income, work, and racism. After graduating from the Woman's Medical College of Pennsylvania in 1929, she established the Esperanto Health Home in her Philadelphia house. It served as a clinic and convalescent space for Black patients who needed care beyond a brief office visit. Alexander treated people who were poor or medically underserved and studied the unequal burden of tuberculosis and infant mortality. Her work connected bedside practice with public health investigation. If a patient returned to overcrowded housing, unsafe work, or inadequate food, the social cause of illness remained in place. The home also offered maternity care, treatment for minor surgical problems, and a place where patients could recover under supervision. That model makes this stop especially important. Alexander was not waiting for a perfect hospital system to arrive. She used the resources she had to create a trusted, community-facing institution, while also producing evidence that exposed racial disparities. As an African American woman physician, she worked against two linked exclusions: the exclusion of Black patients from equitable care and the exclusion of Black women from professional authority. Her legacy asks us to widen the definition of medicine. It includes examination and treatment, but also research, organizing, education, and the stubborn decision to keep a door open for people whom larger systems had failed. Imagine this house as a working health institution, not merely a private residence, patients arriving, families asking questions, records accumulating, and a physician turning local experience into an argument for structural change. Add another case to this record without confusing it with Alexander's own community care. In the 1990s, researchers recruited Black and Hispanic boys in New York City for a fenfluramine study that investigated whether a drug affected aggressive behavior. The study raised serious questions about consent, the use of children, and the way racialized theories can turn ordinary behavior into a biological hypothesis tested on vulnerable families. This case belongs in a history of experimentation because the harm is not limited to needles, surgery, or infection. It can also come from a research design that treats Black children as evidence for a theory about race and behavior. The lesson is why Alexander's model matters. Health work must begin with trust, context, and the dignity of the person in front of the clinician. At this stop, begin with the archive itself. The Barbara Bates Center for the Study of the History of Nursing helps gather nursing history through objects, oral histories, institutional records, photographs, uniforms, and the stubborn work of curation. That matters because nursing is often remembered as background labor even though nurses spent the most continuous time with patients. Black nurses navigated segregation, unequal training access, low pay, and the demand to be both technically excellent and emotionally indispensable. An archive can change that picture by preserving their voices and professional decisions. It can show where nurses trained, what their schedules required, how uniforms marked status, and how patients remembered them. Archival work is not neutral in the sense of being automatic. Someone has to seek the records, identify the names, preserve fragile material, and decide how a collection should be interpreted. The center therefore belongs in this route as an active form of repair. Before we talk about hospitals, schools, or epidemics, we have to honor the people who kept the evidence and the people whose evidence was nearly lost. The record also includes the Tuskegee syphilis study, conducted by the United States Public Health Service from 1932 to 1972. Black men in Alabama were deceived about their diagnosis and observed without effective treatment even after penicillin was available. This was a deliberate study of non-treatment, not an unfortunate failure to provide care. Henrietta Lacks's cervical cancer cells were taken at Johns Hopkins in 1951 without her knowledge or permission for research use. The resulting HeLa line transformed cell biology, while her family was not informed for decades. The cases are not identical, but both show why consent, family rights, and control over biological material matter. A responsible archive names the people and the institutions, not only the discovery that followed. Here, focus on scale. Mercy Douglass Hospital represents what happens when Black medical labor becomes infrastructural. Mercy Hospital and Frederick Douglass Hospital merged in 1948, joining two institutional histories that had served Black Philadelphians for decades. The merger was not simply a change of signage. It gathered patients, physicians, nurses, administrators, students, records, and community expectations into a larger system. Care, instruction, administration, and neighborhood survival began to share the same walls. A hospital like this meant more than treatment beds. It meant a place where a Black physician could gain experience, where a nurse could teach the next cohort, where a family could find a familiar advocate, and where a young person could imagine medicine as a profession rather than a closed world. It also created standards and collective memory. When a patient was referred, when a procedure was documented, or when a student passed an examination, the institution accumulated credibility that no single practitioner could build alone. The hospital's later closure in 1973 is therefore not just an administrative fact. It marks the loss of a major Black medical anchor during a period when hospital consolidation and changing healthcare economics could weaken neighborhood institutions. Carry this stop forward as evidence that Black medicine was not a temporary supplement to the city. It was a serious institution capable of carrying a community's needs, training professionals, and producing its own history. Standing here, think about training as aspiration and resistance at the same time. Frederick Douglass Hospital opened Philadelphia's first nurse training school for Black women in 1895, and the Mercy Douglass tradition carried the commitment forward. Training meant anatomy, hygiene, medication, observation, emergency response, and the disciplined routines that made a hospital safe. It also meant navigating a profession in which Black women were often expected to provide care without receiving equal authority or recognition. A cap or diploma may look ceremonial, but each one marks labor that had to be excellent before it was allowed to be visible. Students did not merely acquire technical skills. They entered a professional network with obligations to patients, classmates, instructors, and the wider community. Graduates could carry knowledge into homes, schools, clinics, public health programs, and other hospitals. That is why nursing schools are engines of community health, not side notes to hospital history. They multiply expertise. They also preserve institutional memory. A graduate can tell the next generation how a ward actually functioned, how a patient was treated, and what standards mattered when resources were limited. Imagine the pressure on a student who knew that a mistake could be used to discredit Black women in medicine generally. Excellence was personal, but it was never only personal. Each successful cohort widened the space available to the next. This stop turns education into a story about legitimacy earned under unequal conditions and then converted into collective capacity. The move bombing site is a place where medicine, government violence, and the treatment of Black bodies cannot be separated. On May 13, 1985, Philadelphia police dropped a bomb on the Move house at 6221 Osage Avenue. 11 people were killed, including 5 children, and 61 homes burned. The city's official investigations later documented failures in planning, command, fire response, and accountability. Those facts belong to the history of public health because health is not only what happens in a clinic. It includes whether people can remain safe in their homes, whether authorities value their lives, and whether families receive truthful answers after catastrophe. This stop also carries a second wound. Remains of 2 children, Tree Africa and Delisha Africa, were retained by medical and academic institutions and used in educational settings without meaningful family consent. The handling of those remains became a further violation. Bodies connected to a state-inflicted disaster were again made available to institutions that claimed scientific purpose. Be precise here. The bombing itself, the destruction of the neighborhood, the loss of life, and the later mishandling of remains are connected, but they are not one undifferentiated event. Each demands its own accountability. The roots medical question is simple and severe: who has the authority to examine, classify, teach from, or possess a black person's body? A responsible answer requires consent, family rights, transparency, and the recognition that scientific interest does not cancel human dignity. Stand quietly and let the address remain a home, not just a case study. The remains issue has to be described with the same precision as the bombing. After the 1985 attack, the remains of Tree Africa and Delicia Africa were handled by medical and academic institutions, and portions were retained or used for teaching without meaningful family consent. The Move Commission and later reporting document a chain of custody and decision-making that families did not control. This was not ordinary pathology. These were children killed by a state action, whose remains were then treated as institutional material. The later use of the remains in teaching made the original violence continue in another form. The children were denied privacy and their family was denied authority over what happened to their bodies. Medical ethics requires more than a technically lawful transfer. It requires consent, accountability, respectful return, and an understanding that the scientific value claimed by an institution cannot outweigh the rights of the dead and the living family. Name this as experimentation and exploitation only where the record supports it, name the bombing as state violence, and name the remains handling as a separate violation. Precision strengthens the indictment. It does not soften it. Holmesburg Prison is one of Philadelphia's most important sites for understanding unethical human experimentation. From the 1950s into the 1970s, dermatologist Albert Klickman conducted studies on incarcerated men, many of them black, testing products and substances for pharmaceutical, cosmetic, chemical, and military interests. The experiments included compounds applied to skin and research connected to treatments for disease, and the prison became a controlled environment where researchers could recruit people whose freedom was already restricted. Payment and the promise of medical attention did not make the arrangement equal. A person in prison cannot negotiate consent from the same position as a free volunteer, especially when the researcher controls access, information, and the conditions of daily life. This is why the history cannot be softened into a story about pioneering dermatology. Klickman's work produced knowledge and commercial value, but the benefits were distributed upward while the risks were imposed on people with limited ability to refuse. The racial dimension matters because black men were not incidental to the history, they were overrepresented in a prison population shaped by unequal policing, sentencing, and economic conditions. The ethical lesson is not only that a particular doctor behaved badly. It is that institutions can turn vulnerability into a research resource when oversight is weak and scientific ambition outruns human rights. At this stop, ask what real consent requires: understandable information, freedom from coercion, an independent review process, the right to withdraw, and a fair relationship between risk and benefit. Holmesburg belongs in a Black Medical Legacy tour because it shows the opposite of community care. Frederick Douglass Hospital and Virginia Alexander's Clinic built trust to serve Black patients. Holmesburg shows what happens when institutions use Black bodies while denying the people attached to those bodies equal power. The details are more extensive than a label about unauthorized testing. Klickman and collaborators used incarcerated men, many of them Black, in studies involving infectious agents, skin irritants, drugs, radioactive materials, and industrial or military compounds. Men awaiting trial or unable to afford bail could not exercise the same freedom to refuse as outside volunteers. Payment did not erase coercion when prison controlled work, healthcare, movement, and information. The products and findings moved outward, the risks stayed with prisoners. If this stop is taught only as the origin story of Retin-A, it celebrates the marketable result while hiding the people who bore the risk. The full history includes the substances, restricted consent, racialized incarceration, lawsuits, and the demand for repair.